WFSA webinar on the role of anesthesiologists in disaster management. As we all know, that WFSA's 2025 theme is highlighting the essential role of anesthesiologists in health emergencies and critical care. Today's webinar is a part of series of activities to celebrate this theme. WFSA and Intensive and Critical Care Medicine Committee of WFSA is leading the organization of this webinar, which is highlighting the vital contribution of anesthesiologists in disaster management and critical care scenarios. I am joined by my co-moderators, Dr. Karima Khalid, WFSA ICCM committee member, lecturer and senior consultant at Muhimbili University of Health and Allied Sciences and Muhimbili Orthopedic Institute, Tanzania. I, Dr. Naveen Malhotra, am director of AS Pain Management Center, Rohtak, Haryana, India, and I am currently the president-elect of Indian Society of Anesthesiologists National. It's my pleasure to welcome my third moderator, Dr. João Manoel Silva, JR, who is also WFSA ICCM committee member, director and head of medical education for the Department of Anesthesiology at Hospital do Servidor Público SDUL, Brazil. The intended learning objectives for today's webinar will be spearheaded by the speakers that why anesthesiologists need to be involved in disaster planning, where to start by Dr. Hilal Ayoglu. Dr. Chaim Greenberger will speak on from the battlefield to OR, preparedness in a conflict zone, and Dr. Joseph McIsaac will discuss on managing combined trauma and chemical, biological, radiological, and nuclear exposure. And then subsequently, we have discussion on the question answers coming up during the webinars. You can submit your questions via the Zoom Q&A function, which is there on the bottom of your screen. This webinar uses Zoom AI translation features for live subtitles. You can select your preferred language in the settings. Certificate of participation will be issued within 15 business days of the webinar. But for that, you must attend the webinar for at least 60 minutes. The recording will be there on the YouTube within 48 hours, and a link will be sent to you by email. I now invite my co-moderator, Dr. Karima Khalid, to introduce the speakers.
Thank you so much, Dr. Malhotra, for that good start of the webinar today. And it is my pleasure to welcome Dr. Hilal Ayoglu, who is a professor of anesthesia and an intensive care specialist based in Turkey. She is the head of anesthesia department at the Zonguldak Bülent Ecevit University Faculty of Medicine. Ayoglu is the European regional representative of the WFSA, a member of the WFSA Safety and Quality Committee, and an active member of the Turkish Society of Anesthesiology and Reanimation, and a psych. She is the former Secretary General of the Turkish Society of Anesthesiology and Reanimation at the Balkan Anesthesia Platform. She's also the chair of the Patient Safety Scientific Committee of the Turkish Society of Anesthesiology and Reanimation. Ayoglu is an author of many scientific publications, and she has her areas of interest include patient and employee safety in anesthesia and education. Please welcome Dr. Hilal Ayoglu to speak to our audience.
Dear colleagues, it's an honor for me to be with you. Dear chairmen, thank you for your introduction. I extend my warmest greetings to all participants joining us from different parts of the world. Today, we will address a highly important and timely topic. Why do anesthesiologists need to be involved in disaster planning? Where to start? Disasters surpass local capacity and require external assistance at national or international levels. They can cause significant damage, destruction, and loss of life, and they appear as unpredictable or sudden events. The number of disasters and the wide and diverse risks associated with disaster-related health problems are increasing at the global level. In 2024, the Emergency Events Database recorded 393 natural disasters. These events caused more than 16,000 deaths and affected approximately 167 million people. Economic losses were approximately $240 billion. In 2024, extreme heat events that caused the deaths of thousands in Asia, severe droughts affecting more than 25 million people in Africa, and devastating tropical storms in the United States causing damages exceeding $100 billion were experienced. What is important for disaster is not if, but when they happen. Although disasters are unpredictable, their numbers and effects have become increasingly devastating with the increasing world population. It is clear that disasters, whether natural or man-made, create great devastation and pressure on the health system. And the need for anesthesiologists and perioperative team preparation in disasters is increasing. Although the number and frequency of disasters vary between countries, it is clear that disasters will continue to affect us, and it is essential to prepare for this. In disasters that are caught unprepared, there is a partial collapse of health systems. Disasters damage health infrastructure and hospitals, as well as disrupting the ability of doctors and health teams to provide service. Managing the aftermath of disaster requires coordination and strong responses in the health sector. Effectively responding to a disaster requires the creation and implementation of a disaster response plan in advance. The 5 stages of disaster management cycle are prevention, mitigation, preparedness, response, and recovery. At this point, it is necessary to ask the following question. What is the role of anesthesiologists in disasters? Why should we be a part of this process? Anesthesiologists have a critical role in a disaster. A universal theme in anesthesiologists' job descriptions is that they are extraordinarily broad and adaptable, making them a Swiss Army knife of care for people in all areas of the hospital, at the beginning and end of life. Anesthesiologists are flexible in their ability to adapt and innovate, trained to care for patients of all ages, have the skills to identify and manage patients who are deteriorating rapidly, and are routinely trained to lead teams of medical staff. Approximately half of all injuries after an earthquake are fractures, most of which require surgical intervention. And according to the ASA, the need for surgical intervention in earthquake survivors is 15%. Anesthesiologists will have to work in insecure environments during disasters and will face numerous constraints. Anesthesiologists are key players in surgical and intensive care services during times of crisis. As advocates for patient safety, anesthesiologists need to take an active role in disaster planning and disaster response due to their leadership characteristics, including disaster mitigation, preparedness, response, and recovery steps. Many tasks fall directly within the scope of anesthesiologists' expertise, from emergency surgical interventions in disaster to operating room logistics and management, from pain management to critical patient care. Anesthesiologists have unique competencies in these areas, in particular, rapid triage and prioritization skills, management of emergencies, patient management at the intensive care level, and management of intensive care units, experience in providing safe anesthesia with limited resources, Coordination, including the delivery of emergency drugs and supplies, allows anesthesiologists to make unique contribution in disasters. Anesthesiologists can play an active role not only in the operating room, but also in field hospitals, mobile triage points, and even in field support teams in disaster settings. Where are anesthesiologists in disaster plans? Anesthesiologists who have important knowledge and skills are not included in hospital disaster committees in most places. Although disaster plans are mandatory by law in most countries, unfortunately, the fact that anesthesiologists should be on the front lines in disaster is ignored. An emergency medicine specialist and surgeons are mostly included in planning and hospital preparations, and anesthesia teams are not included in these processes. Their value as responders to mass casualty events is often underestimated. Anesthesiologists are trained extensively and in detail, and as has been seen in the COVID-19 pandemic, major earthquakes, and other disasters, the success of emergency and surgical teams depends on the presence of anesthesia support. In France, anesthesiologists play an important role in pre-hospital and emergency departments during disasters. In the 2005 London underground bombing, anesthesiologists in the helicopter emergency response team work actively, especially for the injured in field amputations. National disaster guidelines published in UK, USA, and Japan emphasize the criticality of anesthesia services in disaster planning. However, in most countries, the guidelines and directives are often inadequate and have gaps. The earthquake that occurred in the Iskenderun and Kahramanmaraş region of Türkiye in February 2023 resulted in the collapse of several hospital buildings. A combination of factors, including a lack of preparedness, public helplessness, poor planning and coordination, and insufficient training, contributed to substantial loss of life. These events clearly highlighted the vulnerability of even the most advanced systems when faced with large-scale disaster. The Ministry of Health tried to ensure that volunteer doctors could reach the disaster area urgently throughout the country. I volunteered in one of these teams. Unfortunately, I can say that there was a seriously chaotic process in the region affected by the earthquake, and we encountered a large number of amputations and crash syndromes. I took part in the perioperative management of these patients and in the operating room and intensive care organizations. There were serious deficiencies in our local or regional disaster plans for such a major disaster. What happened to my country today could happen to another country tomorrow in a different dimension. Therefore, we need to start somewhere. Where should we start as anesthesiologists in disaster planning? Disaster planning requires multidisciplinary healthcare systems. Anesthesiologists will have positive effects on care and patient outcomes in disaster situations. Anesthesiologists can make quick decisions by evaluating data from the field during disasters and can easily manage and organize rescue operations with their leadership, crisis management, and communication skills. For this purpose, for institutional integration, the anesthesia department should have a special section in the hospital's disaster action plan. Anesthesiologists should be represented in disaster preparedness committees. The anesthesia team should take an active role in field drills. Fair access to safe anesthesia should be provided, especially in emergencies. There is a clear need for disaster preparedness training throughout the professional careers of anesthesiologists. While disaster medicine has been integrated into anesthesia training curricula in Germany, for example, and several other countries, Such training remains insufficient or absent in many national anesthesia education programs. The title Disaster Medicine and Anesthesia should be included in the residency training curriculum. The training will also initiate awareness. National anesthesia associations should create certified disaster training modules. Simulations should be conducted with disaster scenarios on topics such as intensive care, ventilation, sedation, crisis management, maybe communication skills, and etc. In logistic and material planning, the availability of anesthesia drugs in disaster should be reviewed. Mobile anesthesia sets, portable monitors, and oxygen sources and ventilators should be included in the planning. Alternative protocols that work with minimal resources to provide sedation, anesthesia, and analgesia should be created. For collaboration and coordination, protocols should be developed and collaboration should be established with organizations working in disaster, for example, ICRC. As international examples, disaster anesthesiology teams can be established. Anesthesiologists should be involved in field hospital planning from the early stage. WFSA resources and training networks should be utilized. In disaster situations, anesthesiologists may have to work under difficult conditions, including shortages of medication, logistic resources, and personnel. They might be psychologically challenged by post-disaster traumas, burnout syndrome, emotional burden, and decision-making pressure in the absence of resources. Therefore, disaster planning should include not only technical training, but also ethical and emotional resilience training. Dear colleagues, disaster don't fade. Be ready. In situations that carry the entire burden of the system, such as disasters, preparation means the resilience of society. Therefore, my call is clear. Anesthesia associations, universities, hospitals should develop institutional reflexes on this issue. Every anesthesiologist should be included in the disaster plan of their own institution. Let's not forget. Disasters happen one day, but preparation should be every day. Finally, I would like to say that preparation is not a luxury, but a professional responsibility. Anesthesiologists should take on a leadership role in disaster preparedness. As a member of the WFSA, European Council and Safety and Quality Committee, I strongly believe that there is something we can do. I would like to call on all anesthesia associations to seriously prepare for disaster and take action. I have endless faith that strength comes from unity. Please advocate for taking part in disaster planning, participate in plans, and take part in trainings. WFSA will continue to support and establish connections. Thank you for your attention. Also, I invite you to the WCA Congress to be held in Marrakesh in 2026. Thank you very much.
Oh, thank you so much, Dr. Hilal Ayoglu, on that very compelling presentation. And we've learned a lot. What disaster can do, and that we need to be prepared when these disasters happen, and that we as anesthesiologists are not included in the planning. And we really take your call into consideration that we all, in our settings, wherever we are, we should advocate for our inclusion into the planning for disaster preparedness and management. Thank you so much for that. Now, I would like to welcome Dr. Greenberger, who is a certified anesthesiologist in the Tel Aviv Sourasky Medical Center. He's a certified OB or obstetric anesthesiology fellow in charge of mainly the resuscitation team of the OB department. He's the secretary of OB anesthesia of the Israeli Anesthesiology Association, and he's a reserve combat division special rescue team in the Israeli Air Force. And he'll be talking to us today about preparedness in the conflict zone, from the battlefield to the OR. Welcome, Dr. Greenberger.
Thank you very much. It's a pleasure for the opportunity to present you today regarding our lessons, our experience from the last 2 years. Um, I have nothing to declare. However, I do emphasize that this is only medicine and learning how to be much better, and no politics is involved in this lecture. We will start. Um, 1 second. Great. So, this lecture will show the components of our action to reduce the casualty fatalities rate from 10 to 15%, which is common knowledge, to less than 6% among all casualties in our last 2-year conflict, and emphasizes the role of specifically why anesthesiologists should be inside the mainly area of a disaster area. We will speak about the qualifying anesthesiologists as part of the intensive care squad of the field, and from the field to the hospital. We will speak about the short distance, or making the distance short, from the disaster area to the OR, with specific qualification of physicians who take those casualties, the personnel, to the hospitals. We will speak simply regarding a simple triage, which can be conducted by the anesthesiologist, and prioritization of the wounded patients, regarding time, regarding procedures. Um, then after, we will speak about specific equipment that can help to reduce this casualty fatality rate, especially whole blood that we use inside the field. And then we will just take a little bit of comments regarding why the anesthesiologist is a good qualified and much better to manage the disaster areas. So let's start regarding our system in Israel. Our system in Israel, every 18-year-old has a mandatory service in the army, which takes place about a few years, more or less. Some of them can learn medicine before, or actually start their service in the faculty of medicine, um, being the doctors, and then deploying for about 5 years in the military service. However, these doctors have much less experience in the battlefield. So we mainly rely on the large reserve medical personnel. Those are outnumbered and out experienced for those kind of disasters management. Um, and the system is built very good in order that we have fast recruitments. Most of our anesthesiologists who serve in the army as well, they work in the hospitals as everybody, but they have a capability in less than 24 hours, if needed, to emerge and come to the to serve. So regarding the personnel itself, in our ground team, we have physicians, a company level with 2 medics, which actually they perform a medical squad. Those physicians are not specifically trauma team physicians, could be any physician, due to lack of physicians. But after all, we built a new mobile intensive care, which is in a brigade level, and those are actually trauma specialists, which include surgeons, intensivists, and anesthesiologists. The cons regarding this system is actually most of the physicians who are reserved physicians, they work daily in their hospitals, and they're not used to field medicine, especially the paramedics, especially nurses and doctors. Although we have the trauma room, but the capacity of those cases and the injuries are much different. So part of the training in those reserved medical physicians is also to change actually the mode of thinking and the area of working, due to the most of the time they are not in the battlefield and they're in the civilian hospital. In addition, as quoted before in the previous lecture, there's a big mental burden on those physicians, especially anesthesiologists, who have the front of combat field, and they experience a lot of emotional issues regarding taking care of those wounded inside of the battlefield, which is most probably different than their daily working in the hospital. Let's talk about the distance. We know that once a patient is wounded or a soldier is wounded, the critical issue is to bring him to the OR or to the level 1 center, and by the least time that we could. In our experience, in our area of the conflict, it's a bit easier to do that because we have a lot of hospitals among the conflict area, which left us to have less than 45 minutes from the time to the injury itself to the ER and to the OR itself. So we have about 8 hospitals. 6 of them are level 1 hospital, which is less than 1 hour distance, either by driving or mainly by helicopters. So the distance of giving the wounded soldier the best treatment is it's very crucial. In addition, I'll show you now a specific slide, a specific video shows that, our capability to have medical teams in no time from the injury itself, and our special intensive care units. We have a special motor vehicles. Comes together to the area of the wound and takes the patient very fast during treatment, intensive care treatment, to the helicopter, and from the helicopter to the hospitals. So let's start. If you hear me, this is the medical squad. The intensive care squad has information regarding wounded patients. This is on the field, and from the field, we land helicopters inside the combat area, in frontal area, which gives us the opportunity to treat the patient very fast and to take the patients to the helicopter, and from the helicopter to the hospital. See here, this is very close to the area of the explosion. And our intensive care unit, which is on the vehicles, receive the patients from the area. And now during driving to the helicopter, they're actually treating the patient in a very high medical quality, including anesthesiologists and intensive care physicians, straight to the helicopter. Look at the sand and the wind. It's very difficult to treat those kind of patients, and we have a lot of training to do that in a good manner with the very best equipment that we have. This is another example. The medical squad team until the point of combination with a helicopter. Okay, so not only the distance influences the patient's survival, but also the personnel who treats them. We have small teams of physicians and paramedics that are not intensive care units, are not anesthesiologists, more surgeons who have capability of treating the patient with their own skills. But from the area of the wounded patients to the hospitals, we saw that anesthesiologists, part of a squad team of intensive care physicians, make very, very big difference. And not only for the single patient, but also for mass casualties. We had 36 mass casualties events. The importance of the anesthesiology, you can see here, the medical squad, they can do we have 2 options, or to land the helicopter, which have inside the helicopter the intensive care unit physicians, which included the anesthesiologists, straight to the helicopter, okay? And then we have a second choice to take them with a vehicle, with an intensive care unit inside, an armored intensive care vehicle, outside to a landing zone, which then the helicopter can take them straight to the hospital. So in addition, the anesthesiologist can have crucial decisions to make in the place itself. The distribution of patients, we have like, if we have a major event of 5 wounded soldiers, we need to prioritize those soldiers in order to who goes first. If we need to do procedures in the field itself, the severity of the wounded and where can the soldier and the wounded soldier can go, which hospital can go, and how many uh, wounded soldiers can go inside a one vehicle or a helicopter, which gives us enough space, is enough efficient to take a good treatment for that soldier. We have a lot of experience in those mass casualties, unfortunately. Just look about those kind of numbers. We have 396 operations, 790 soldiers were injured soldiers, and we had 193 helicopters landing inside the combat field or just near the field. So the next couple of slides will speak about the specific equipment, mainly the whole blood that we encountered inside the field. Now, nowadays we have blood that goes inside the combat field itself. This graph shows us the percentage of the wounded and the dead soldiers from the time of the blast itself. I'll show you the numbers that you can see here in the graph. KIA is killed in action, and DOW is died of wounded. You could see in the first golden hour, most of the casualties die unless we start the RDCR early. RDCR is remote damage control resuscitation. And for that reason, once we started to implement whole blood inside the field, so we saw a decrease in our fatal casualty rate. But that's not enough to have a decision to give blood. We need the correct personnel to know how to give blood. We know that hemorrhagic shock of patients can make a very big difficulty in order to receive a good access for giving whole blood inside the patient. So the anesthesiology inside the field, together with the intensive care unit, does not only bring the blood to the field, but also makes sure that the blood is given in a good manner with good access. So that made a big difference. How do we take the blood inside the field? So it's a very big logistics, but we implemented a new kit that can take the blood with a cooler inside, and those blood units are on the back of our soldiers. From the citizens who give blood during the disaster time to the blood bank. Blood bank makes the blood products good for giving to the patient, and then out to the field in special kits that we have to those physicians, and actually to all, even the small medical squad. So I will finalize why specifically anesthesiologists. We have many physicians who can do those kind of reserve military service. We don't have so many anesthesiologists or surgeons to go inside and to take care and take part of a 2-year war, unfortunately, because the anesthesiologist has the skills to not only to decide when to do a procedure, but mainly to reduce unnecessary procedures. I will show the next slide. What do I mean? Time-consuming procedures, complications during the procedures, who other physicians do not have any skills about. Advocate fast evacuation, which we saw before, that those characters of the patient itself is one of the high importance to bring them to level 1 ER as soon as possible. And much more higher skills of the anesthesiologist regarding management of blood products, regarding management of shock, and regarding management of airway management, which most of the wounds during the war is those kind of wounds. I will show you one case. So this is, for example, it's an injured from explosive device, okay, inside a building. We have a significant head trauma, burns on the mucous membrane. Saturation of the patient is 97% with oxygen. Okay, he's in touch. He's fully aware. He can't speak because he has a lot of blood and a lot of wound inside his face. What do we do now? Do we wait Do we start to manage his airway in the field? We know there's complications and it's suboptimal to start treat this patient in the field. But we also know that we have 5 minutes away with the intensive care unit, with the intensive anesthesiologists, with the surgeons, 5 minutes away, a helicopter that can bring those patients in about 17 minutes to the ER, to the OR. So do we start to manage this airway? So that's the importance of the anesthesiologist inside the disaster area in order to get the right decisions, and if the decisions are correct, to manage those kinds of casualties and fatalities in the best manner. So I will conclude. This system is not good for every Zor or for every disaster area. The conflict-specific criteria, in order, like in Israel, we have short distance of evacuation and a lot of hospitals around. What happens if we have a long distance of evacuation? We need to leave the patient 2, 3, 4 hours inside the disaster area. Okay, we need a strong hinterland. We need a small citizens of hospitals that can manage without those physicians, anesthesiologists, surgeons who go out to the field for 2 months, 3 months straight, and the lack of those personnel in the hospital should be managed. And we cannot forget, once the severity score goes up, so we have much more ICU beds and much more need for rehabilitation beds in order to treat those soldiers, wounded soldiers, severely wounded soldiers, and give them back the chance to have a normal life. Thank you very much. And if you have questions, I will be glad to answer later. Thank you.
Thank you so much, Dr. Greenberger, for that very good presentation on how the coordination of a team can help to save lives. And you see, the food for thought is really good when you have short distances and you have well-coordinated teams and all the resources. And it's tough, as you can imagine. It's much tougher when you have longer distances, more casualties, less and less capacity to do this kind of coordinated work. So there's a lot to learn and a lot to synthesize for other areas and other places where maybe resources might be more less as compared to how they are where you're working. Thank you so much. And I will now welcome our last speaker, Dr. Joseph McIsaac. He began his dual civilian and military medical career in 1982, and later commanding an Army Rapid Deployment Force medical team and advancing disaster preparedness through extensive CBRN casualty treatment training. He developed key disaster management techniques adopted from the American Society of Anaesthesiologists and authored 2 books on all hazard preparedness. He served as a clinical professor of anesthesiology at the University of Connecticut and chief of trauma anesthesia at Hartford Hospital, with research in innovative medical devices in trauma care. He's an active leader and entrepreneur. Dr. Isaac has founded technology, set up, earned an MBA, and continues to serve on national committees, reflecting his commitment to advancing medical practice, preparedness, and hospital system improvement. And today he's going to be talking to us on managing combined trauma and CBRN exposure. Thank you so much and welcome, Dr. McIsaac.
Thank you very much. So I'm no longer with University of Connecticut. I'm in private practice now, but I'm continuing my academic adventure regardless. I have about 8 hours worth of slides here that's condensed to an hour, now condensed to 15 minutes. I do have some disclosures, 2 books, and I continue to work part-time for the U.S. government. I'm going to skip a lot of the formalities and get right to the meat of the problem. This slide is the summary of the entire talk. When you have a traumatized patient who's also been exposed to either a biological, a chemical, or a radiological source, it's critical to make sure the responders, whether in the field, the emergency room, or in the hospital itself, are wearing the appropriate respiratory and contact personal protective equipment. Otherwise, you become a casualty yourself and are no longer able to help others. Once the initial triage is done in the field or in the hospital, we do immediate life-saving procedures. Essentially, we do these things simultaneously: bleeding control, airway control, chest tubes if needed, antidotes if they're appropriate. If it's a biological patient, we isolate the patient. If it is a patient who has been chemically contaminated, we do decontamination and hopefully try to identify what the agent is so we can do specific treatment later on. If it's radiological, then we decontaminate. Decontaminate really means stripping the clothing and washing with water and soap, or if not available, dry agents like sand to remove as much of the surface contamination as possible. And then followed by advanced trauma life support and damage control surgery. And then finally, we treat the disease. If it's biological, we treat the toxic drome. If it's chemical, and we do the we treat the advanced the radiological syndrome or any internal contamination. You're free to use this slide if you would like, even though I've copyrighted it. As long as I get some attribution, I'm happy to allow this to be used however you would like. So we're going to skip a lot of these formalities. We all know there's all kinds of different types of exposure that we can have out there. One critical topic, which is really a lecture in and of itself, is everyone should know some type of triage technique. The U.S. government favors the SALT technique, which I show here, which is very easy to remember for those of us that don't do it very much, but there's START, Jump Start, and other types. It doesn't matter which one you use as long as you have a way of triaging and deciding which patients get the priority treatment and which don't. We've all been through COVID, unfortunately, and many of us have taken care of trauma patients who've been exposed or were ill with COVID, so we know about isolation. There's many, many diseases to worry about. Some of them are used in biological warfare, some of them are garden variety, many are pandemic related. I'm going to skip through most of this material simply because we don't have time for it today. Everyone should be getting a copy of my slides as a PDF, and you're welcome to use those as you need to. And there's a lot of great references, such as this one on chemical agents, whether industrial or warfare agents. The U.S. government makes this freely available. Please utilize it. It's a great source. Many industrial accidents, which are the most common things that we will be seeing, and sadly can be on a very large scale. And I don't have time to talk about specifics. Use of chemical weapons by various countries in warfare. I only chose a single one for time here. We're not going to dive into all the details. Again, this is another separate lecture. But understand that the first priority is to assess the situation and protect yourself. If you're in the field, establish a hot zone and then triage the casualties in a way that you can prioritize who you can help and needs the help right away, who unfortunately can't be helped with the current resources, and who can wait a while. Again, the SALT triage system is easy to learn and very easy to remember. You can find slide sets online that will allow you to teach it to yourself without having to go to a formal class. All of these systems categorize into 4 or 5 classifications, from immediate to delayed, minimal, expected, and dead. The people that unfortunately you're unable to help with your current resources. Decontamination can't be overemphasized. Water is best, water and soap, obviously. You can use sand, absorbents, or minerals. There are specific chemical formulations you can purchase that are excellent on warfare type agents. Sodium hypochlorite in dilute concentration is especially bad for the sticky things like mustard and some of the nerve agents. As we all know from COVID, if you're in PPE, it's much more difficult to do the common manual procedures. Consider strongly putting in LMAs rather than doing intubations if it's possible. And if it's not possible to easily facilitate intravenous access, intraosseous is faster and works very well. There's many references out there for you to look at. If you're an anesthesiologist who will be managing the operating room, the American Society of Anesthesiologists has prepared a checklist that will help you figure out which tasks you need to do immediately, which can be delayed, and what to think about for later on in the event. That's available on the ASA website. Unfortunately, it's still behind the paywall. We're working on getting that out for you. I can send you a copy if you email me. My email's at the end of this talk. So with chemicals, there are a number of toxidromes, as we call them. Classes of chemicals will give you various common symptoms and signs. The chemical inhalation asphyxiants, they can be water soluble or poorly soluble. There may be chemical burns, and some agents cause a metabolic intoxication. I'm going to skip these for the ability to get through this on time, but they're in the slide set that you will get. Chemical burns are especially difficult to treat and have a high lethality. The warfare agents also, there's a fair amount of literature. It's old, but it's still relevant. You can look this up. The United States government has this material on their website, and you can easily access it for free. The metabolic poisons can be warfare agents, or they may simply be industrial agents. This website, chem.hhs.gov, again, another U.S. resource for you. Please look this up. If you're a first responder, you spend a lot of time in the field, or you can give this to your fire people. The Wiser is another U.S. website that's freely available, very helpful for field folks. The meat of this rest of this talk is really going to be on radiation and trauma. Everybody has this innate fear of radiation because we can't sense it. However, this is one of the easier ones to manage because we understand it reasonably well. It can be from many sources. It can be a power plant event such as Chernobyl or Fukushima. It could be from loss or misuse of a medical or industrial device, dirty bombs, and the worst is a nuclear detonation. They all have some very unique characteristics. Where I live part-time in the northern part of the U.S., we have a large number of nuclear plants, so we're always thinking about those things. Dirty bombs can be and have been made. They're a relatively small-scale event, but problematic. And of course, the thing we all worry about as the world becomes increasingly unstable is a nuclear detonation. Most of the time, you see this modeled as a small-scale 1 to 10 kiloton event, but you have to remember nation states have devices that are 1,000 or more times this scale in the megaton range, which create extremely wide devastation and create extremely large casualty numbers. Just one particular model of the fallout plume, which becomes a long-lasting problem for weeks after a nuclear detonation. This model no longer is accessible. They took it down, but you can model the number of casualties and what your hospital and ICU will likely see. So we have to distinguish between radiation contamination and radiation exposure. So you may have external contamination, which has a potential hazard, and you may be irradiated. You potentially may ingest and have internal contamination by a wound, or which could be high or low hazard depending on what it is, and irradiation without contamination. The key to understanding radiation is that there are 4 basic types: alpha, beta, gamma, and neutrons. Each of them are at a particular energy, which may be low in the kilo electron volt range or the mega electron volt range, which is high. And you protect yourself by minimizing time, maximizing distance from the source, and having shielding, which will absorb and prevent the radiation from getting through. There's a principle called the half thickness, which is the thickness of a substance that will reduce half of your exposure. You need about 10 half thicknesses to get into a safe range. You'll notice that for common X-rays in the 100 kilovolt range, you need 1/10 of a millimeter of lead. On the other hand, high intensity sources, such as from nuclear war or medical sources, you need about 0.4 centimeters of lead, which would be too heavy to actually wear. There's this instinct to put on a lead X-ray vest when you're dealing with high-intensity X-rays, which actually concentrates the energy that you absorb and makes it more dangerous rather than less dangerous. So when we're dealing with these types of events, we do not use lead X-ray gowns. I'm going to skip a lot of these safety things, but one of the best pieces of advice is if you live in a high-resource country or have the funds, you can purchase a personal dosimeter for a reasonable amount of money. I have 2 of them that you can wear on your body and know exactly what your exposure is. I had a family member who actually was treated with radioiodine, and I could see when that person was moving around the house getting closer because my numbers would go up and the alarm would go off that I was getting overexposed and I could move to a safer area. But these things are accessible. It will reduce a lot of your anxiety because it takes away the unknown. I highly recommend getting them if you can possibly afford them. How do you know how much radiation your patient has had? Well, there's a very nice chart that demonstrates that the higher the radiation dose, the earlier the emesis, the nausea and vomiting, begins. So patients with lower exposure takes many hours. Patients with high exposure begin vomiting very quickly. You may want to use that as part of your triage tool to determine some relative exposure rate and factor that into your triage. Later on, when you're able to do laboratory tests, you can measure absolute lymphocyte count, which will very nicely, in about 24 hours or so, give you a good estimate of what their absorbed dose was. Decontamination can't be underestimated. You want to get clothing off and the skin clean as soon as possible, whether you have a fancy, expensive setup like this, or you're using very basic techniques. They both work well. The acute radiation syndrome, you're exposed, there's a prodrome, usually that's where the vomiting begins. There's a period of latency, and then the clinical effect occurs, and then either you recover or you don't. The U.S. has a system of hospitals set up to take low numbers of radiation casualties. Obviously, in the event of a nuclear detonation, this will be overwhelmed from the beginning and will serve as technical resources, but not able to handle massive casualties. The higher your radiation exposure, the worse your syndrome, the worse the outcome. You can see from the graphs on the right that there's a period of time where the leukocytes and the thrombocytes, the platelets, are depressed. That's a period of time where you don't want to do any surgery, and the patient's at extreme risk of both bleeding and infection. There's another resource, the REACTS system in the US, which is a great resource online. You can find a lot of great information. Another view of the nadir of your white cells and your thrombocytes. Again, you don't want to operate in this period because the patient will bleed, get infected, and not heal. So you want to either do very early surgery or late surgery a couple of weeks out. Let's talk about triage for a bit. So this is sort of like, I think of trauma exposed to CBRN the same way I think about malignant hyperthermia. It's something that I hope I never see. I actually have seen a case, but most people won't see it in their entire lifetime. But if you do, you need to be prepared. So having these tools in your back pocket, talking about them once in a while, will set you much farther down the road to being able to manage what could potentially be a terrible situation, but made better by your vicarious experience and your preparation. So there are, in a small scale event near a city, you're going to see that mildly irradiated trauma and mildly irradiated patients won't need any care at all. There'll be some moderates and severes, some of whom will be expectant, some of whom need intensive supportive care, which may not be available, some who will need lesser care, and there'll be a large number of injured who have an exposure significant enough to modify their risk strata. This is a slide to show you that mice who have been irradiated with 7 gray of radiation will 100% survive. Mice are better off than people. People don't generally survive at this range. Mice who are infected with Klebsiella pneumoniae, but no radiation, 95% survive. And mice who get them both, nobody survives. So radiation makes you very susceptible to infection. The higher the radiation dose, the less survivable you will be to any kind of infectious process. So one of the big lessons is, if at all possible, try to prophylax against various infections. This is a list of typical antibiotics during a neutropenic event that will be helpful in treating patients who have been exposed to the 4 gray level of radiation. Let's have a couple definitions. Combined injury is a radiation dose above 2 gray with moderate or severe trauma. Severe trauma means that greater than 20% of the patients will die. Moderate trauma, less than 20% of the patients will die. Again, you're going to always have some casualties who have trauma with no radiation problems, some who have a mix, and some who will be so severe they won't be surviving. To put things into perspective, the blue line here is your percent mortality based on amount of radiation with no trauma. The green line is a wound plus radiation. You'll see that there's lower survival. And the red line are burns. Burns start out, even without radiation, having a very high mortality, and it only gets worse from there. Some studies through the US government, which are available within that REM reference that I've given you, demonstrate that there's an increased amount of expectant patients as the level of radiation and the amount of trauma increases. When you live in an area where the resource availability is lower, you're going to have more people that move into the immediate or potentially expectant area. Expectant, again, being folks that we don't have the resources to take care of. They get comfort care only as best you can, and you focus on the patients you do have the ability to save. Again, even if you have the ability to treat the myeloid effects of radiation, if you're in low resources, you're not going to be able to get the drugs that you need in a timely manner to treat everyone. So many patients, unfortunately, will have to move into an expectant category, whereas if you had a few patients, you might be able to save. This is the Radiation Injury Treatment Network's basic algorithm and drug dosing for Neupogen, Neulasta, and Leukine. There's another drug out as well on the market in the United States. There may be others worldwide that haven't been approved in the US. So what are the treatment priorities? Well, first, ensure the safety of the responders. Evaluate and treat the patients with life-threatening injuries. Manage radiation issues, including internal and external contamination and exposure. Remember, you have a narrow window for surgery, so you either do it immediately or you delay it because of the wound healing and the infection risk. Sepsis is a huge concern in moderately and heavily irradiated patients. Consider using prophylactic serotonin receptor antagonists, topical steroids, antibiotics, and antihistamines. Don't use systemic steroids normally. Consider bowel decontamination, enteric nutrition, if available, and fluoroquinolones. There are a number of internal radiation protections. If it's a nuclear power plant, potassium iodide will reduce the radioiodine's risk to your thyroid. You can use removal from the gastrointestinal system. You can use absorptive techniques. Ion exchange has worked, and chelation if you have the resources. We all know about some of these things. This is not FDA approved in the United States, but the Soviets were successful to some extent using activated charcoal and sugar beet pectin during the Chernobyl event on some of their first responders and people who lived close to it. Cytokine therapy, these are the guidelines. There's a new hypothesis of whole body radiation that really says this is a multi-organ injury that can lead to multi-organ failure, and you should focus on treating the inflammation. There are a number of projects out there. This is some of the U.S. government's research. Interesting and non-FDA approved antioxidant gamma tocopherol, which is a vitamin E derivative, allowed 11 gray exposed mice who would have 100% died. They all survived. So if you have exposed mice, I would highly recommend using this drug. We don't know the results on humans at this point. It's not published. It might be worth a try if you have access to it. These other agents, again, are research, and they're completely experimental and currently not approved in the United States. This REM website is invaluable. I highly recommend you use it and download the app. Again, we skipped over a lot of important things, but I gave you resources so you can do planning, training, and just-in-time training should, God forbid, you need it. This is my contact. Anyone who would like to email me, I'm more than happy to speak with you, share my thoughts, and give you more resources. But you will have access to all of my slides, and best of luck. I hope you never need this. Thank you very much for having me.
Thank you so much, Dr. McIsaac, for that very informative talk and for sharing with us resources that we can go to, and and also sharing your contact information so people can ask you for more resources. Now I'll hand over to Dr. Silva for the Q&A part.
Hello, Karina. Thank you for everybody, for all the speakers, excellent lectures. And I have some questions here, and you for free to responses the questions. The first question is about how do you prioritize the patients' care in disaster scenarios where resources are limited, and what is better strategies to evaluate the patients in that case? I know that you talked about something, but you can explain in more details that part. Okay? Hello?
Triage decision-making in disaster requires a different approach because of the scarcity of healthcare resources. Disaster triage algorithms simply introduce primary principles on how to prioritize patients. There are several triage methods, and no one is better than any healthcare professional trained in triage can perform triage. We know from past experience that anesthesiologists will increasingly be involved in responding to future disasters. You may be asked to assist with amputation to facilitate the removal of an interrupted individual. Under these circumstances, you may even involve in medical evacuation. In events requiring rapid patient triage, anesthesiologists can assess a patient's degrees of hemodynamic instability and needs for urgent intervention. Anesthesiologists often manage patient flow through the perioperative setting and may continue to oversee patient placement and transition between the preoperative, intraoperative, and postoperative phases. The implementation of the recommendations may be quite difficult in low-resource and third-world countries, but let's not forget that we are full of skills. At least we can manage the chaotic process rather than doing nothing. Most of us have leadership skills, and I'm sure we can manage the situation quite well in disasters. We can manage other medical stuff very well, and if we plan in advance what to do with few resources, we can prevent great disasters. Thank you.
Thank you, Hilal. And I have more two questions. What are the most advanced methods currently using in hospital for management trauma-associated hypothermia?
So I could tell you regarding the trauma-induced hypothermia. the field, we have special equipments, which is a one-time adapter to actually, even in the winter, give fluids or blood products in a warm 37 degrees. It's like a disposable kit that we take inside to the disaster area. And once we need to give resuscitation of blood products and fluids, we just connect the IV to that container, and it gives fluids and blood products, warming the patient itself. Inside the hospitals, actually, I think all hospitals manage hypothermia induced from trauma. The same rapid infuser with heating. Heating mattresses we have inside the trauma and the OR, and heating the room. We all know that losing blood means losing very fast temperature, like the lethal triad is like hypothermia, metabolic acidosis, and like hemorrhagic shock all together can deteriorate the patient. So it's very important to warm the patient, warm the room, only give warm fluids, especially when there's a massive blood transfusion. It's much easier to do it in the hospital itself, but in the field, we have special equipment for that.
Nice. So I think one case here, though, about pediatric age group school children. If there is a slow diminution of vision, we see after pupils partly dilatate, we see abdominal pain after dinner 24 hours before, no vomiting. What can be the cause of mass affective in child? We see was normal next day. It is villages near intensive care area. Don't know. Someone to
I'm not really
explain
sure
this
what.
question?
So you're describing a particular patient syndrome? Is that what you're doing?
Yeah. I think
He's talking about effect on children on their vision with pupils partially dilated. Children living near the Industrial Development Corporation area, near the factories and the industries, and something is happening to the pediatric patients where the vision is gradually decreasing with abdominal pain but no vomiting. The kids were normal a day before.
Well, when you have dilating pupils, you start thinking atropine-like substances, something that's affecting the parasympathetic, sympathetic nervous system. It could be an ingestion, it could be an inhalation. It's obviously not a, if the patients aren't collapsing and don't have other neurological syndromes, then it's something you at least have some time to investigate. But there's not really a specific agent that it would point to at that point. You'd have to go in there and investigate, taking air samples, water samples, look at whatever's happening in the industrial area, what type of industry it is, what substances are being used at the time. If you have if it's really turning into a mass casualty event, then you need to evacuate the area, obviously, and make sure that the first responders are wearing appropriate respiratory protection while they're assisting the casualties. But what you've described here is a relatively slow onset event that sounds like a poisoning of some sort.
Right. Thank you.
Okay, thank you. There is one question very interesting about the blood transfusion. How can blood transfusion protocols be adapted in disaster scenarios? Holy blood being used in battlefield disaster areas? Is it a ONEG universal donor blood, or some quick groups and the cross-match methods is used?
So
Think
we
how
use
can
Yeah, so we use it's not a one-person donation. It's from the blood bank. We use our blood products as an AB plus in order to match all soldiers, but we don't do protocols regarding antigens or etc. We do only ABO compatibility, and the protocol once we have it's matching for everybody. So we don't check the blood type of the wounded patient, of the wounded soldier. We give a universal blood that everybody can get. And that's the big problem because we need a unique blood donations for once we have a disaster area, and the capability of the citizens who have those kind of blood types, or that for everybody to come and donate blood.
Okay.
So this becomes a problem when you have mass casualties. I'm talking, thousands, tens of thousands of casualties potentially.
Yeah.
And
Yeah,
these are
that's-
conversations that have to be held at a higher level with whoever does the blood collection on a routine basis. In the United States, it's primarily the American Red Cross. Other countries have potentially other organizations that do these things. You can do relatively quick ABO compatibility studies with little kits that I've seen in the field. But again, you need to speak in advance with your transfusion medicine physicians in your institution, with officials at these organizations to determine how you can rapidly collect blood in a mass casualty emergency and do appropriate cross-match in low resources. And again, those are things that you don't want to figure out after the event happens. These are things to start thinking about now, having those conversations, come up with a system that's workable when there may not be power, you may not have running water, you may have other kinds of infrastructure degradation. You'll probably initially only have blood that's on hand, and you may only want to use it in the patient you're sure will survive. You're going to do triage in a large-scale event. So, somebody comes in blowing a pupil because of massive head trauma, they're not going to the operating room. They're going to be put aside, unfortunately, so that you can help the person who has a discrete hemorrhage that you can actually stop and save. So the whole principle of triage will be based on what your resources are currently and what your expected resources are in the near term. And you're going to have to do this on the fly, unfortunately. Communicate amongst yourselves as best you can and do the best you can. So the whole idea of triage is categorizing patients into those you can take care of that need your care immediately, those you can't take care of, and those who can wait a while. The system doesn't matter. It's whatever you can do and remember that works. And again, as I said before, you can train online on your own simply by going through some of these slide sets that people have made freely available. And they have patient practice sets that you can use. And there's courses out there. The Advanced Disaster Life Support System has some free online material on disaster preparedness and on disaster response that includes triage, but there are many other resources. Everybody should learn triage. That should really be part of the curriculum for anesthesiologists, nurse anesthetists, and of course all emergency providers.
Okay. I think more two last questions because the time, but I think one question's interesting here. It's about the management in difficult area airway. It's about intubations. How do you manage the difficult airway in that scenarios? No, that you are.
Depends on what you have for equipment. It depends on what you have for time. It depends on how many other patients you have to take care of. So the first thing to do would be to triage and determine whether you have the capabilities of helping this patient without doing it at the expense of someone else who you could help more. And then what tools do you have? Are you in PPE? Are you wearing a respirator or not? Do you have chemical gloves or not? Do you have the ability to intubate? the right resources. Is it appropriate to intubate? Would an airway suffice? Should you do a surgical airway? These are judgment calls that really depend on the situation you're in and what you've prepared for.
Okay. What is the common complications registered in battlefield? What do you think? The common complications, the most common complications, I think, registered in battlefield.
Well, we had the question was in the battlefield, the common complications in the battlefield.
Yes, yes, yes.
So actually, we had several papers of that. Most of the casualties are hemorrhagic shock. We have numbers of patients who had casualties regarding airway casualties, but those, most of them are can be treatable after most of those casualties. We learned that are not fatal in those who survive. So there are several cases that we need to intervene immediately, but most of the above 80% of the casualties in the battlefield are from actually blood loss. So due to that issue, it's very easy to treat. Once we put on a tourniquet on, once you give back the blood as soon as possible, and once the evacuation to OR is as fast as possible. Regarding the airway contusions, most of them wounded in the battlefield who are still alive and can manage mainly with oxygen supplement and avoid unnecessary procedures in the airway in the battlefield, because we learned that those are much less efficient for saving the wounded. It's better if the patient can stay with oxygen until he comes to level 1 premises, unless he deteriorates in front of our eyes and eventually the procedure is needed. But those are the minor patients that need controls. Most of them are hemorrhagic shock. And we have like explosions, smoke, inhalations. We have like amputations in the battlefield, blurred visions. But the actual killing casualties are mainly from hemorrhagic shock.
Oh, a lot of people talk about the low resources. If there is something different to do in that cases in low resources countries, I don't know. What do you think about that? No.
As noted before, low resource countries, once you have a limited resource, especially in the pre-hospital, so the triage is the most important thing. We cannot waste on a patient which is unconscious with dilated pupils, procedures and blood units where we have 10, 20 injured patients. Can we salvage? So I think the triage and training triage and decision making, when to open kits, when to use equipment in those kind of areas and those kind of countries, training of triage. That should be the goal.
Hilal,
Uh,
you
I'd
want?
like to remind my colleagues who lives in low income countries, there are several guides and manuals on website. You can check this, and also not only American Society of Anesthesiologists guidelines, but also WHO has a disaster management guide. This guide includes best practice protocols for clinical procedure safety, needs assessment, essential emergency equipment list, anesthesia, resuscitation, and etc. You can easily access the preparations and documents of many associations on the subject by searching the web. And also, I would like to say that WFSA is in a preparation phase on this issue because WFSA decided to create a working group on disaster planning. They have various plans, especially to raise awareness on disaster preparedness, prepare trainings and guides, and to organize various courses and disasters and their mitigation. And we hope that this will happen soon.
There is a
Okay,
related
guys.
on the use of feasibility of mobile operation theaters.
So I think we don't have more time. No, it is a long time. It is good discussions here. No, but I thank you for joining us today. This webinar has reaffirmed the critical role anesthesiologists plays in disaster preparedness and the responses, especially the most challenging scenarios. No, we can shape resilient systems and deliver care where it is needed most. No, I don't know if you want to say something else. Be my guest. So if there is no more talking, we can finish that webinar. It's okay.
Thank you all.
Okay, thank you for everybody.
Thank you.
Thank you very much.
Thank you very much, everyone. Thank you, our speakers.
And you are all cordially invited to join the WCA 2026 at Marrakesh in April 2026. And it is our 19th World Congress from 15th to 19th April. You are all cordially invited. The registrations have started and the abstract submission is also now open till 30th September, but don't wait till that time. And we are, please do attend the PWCA webinars every month. The information is there on the WFSA website. Thank you very much.
Thank you. See you soon.
Bye-bye.
Thank
Thank
you.
you.
Thank you.